Good morning, everyone. Thanks so much for having me. I'm really excited to be with you today. It's currently about midnight, I think, in LA the day before. So I'm really sorry that I couldn't be there in person and that I couldn't join you live. Unfortunately, the time zones here in Australia just aren't very friendly. I'm already a little bit jet lagged as well. I've just returned from Bangladesh where we do a bit of work. So I'm really sorry that we couldn't make that work. Look, thanks to Esther and the team for the opportunity to be with you today. I'm going to share a little bit of our work from here in Australia and also from overseas around physical activity and mental health. From an implementation perspective, we'll talk a bit about the evidence and then hopefully some takeaways for any mental health professionals in the room, but also physical health practitioners as well. I know there's a bit of a diverse audience. Also, with any questions, please feel free to get in touch via social media or email, and more than happy to continue the conversation. Okay, so firstly, I'm here in Australia, in Sydney, and it's tradition here that we acknowledge the traditional custodians of the land that we live and work on, and acknowledge the history of colonisation here in Australia. So I'd just like to acknowledge the Gadigal and Bidjigal people here in the lands where I am at the University of New South Wales, and acknowledge their connection to country. For those that haven't been to Australia, this is what some people imagine Australia is like, that everything's trying to kill you. It's not quite that bad, and hopefully some of you have been here or are interested in coming. Everyone's more than welcome. A little bit about where we are, the University of New South Wales. So it's about 15 minutes from that famous beach. Although if you're in LA, this won't be too special for you guys over there. Obviously, the Kangaroos, the Opera House, and the famous Sydney Harbour Bridge as well are all reasonably close by. What I thought we'd start with, and I know that, again, there is a diverse audience in the room, but just talking a little bit about the difference between mental health and mental illness. They are different words. They exist on different spectrums. We often use them interchangeably. But the reason this is important, because when we're talking about the relationship with physical activity, it does differ, and the language is important. So as a bit of an example, we've got on this x-axis, you can see serious mental illness or no mental illness. So obviously we're talking about different conditions there, ranging from schizophrenia, bipolar disorder, major depression, anxiety, some of what we call the more common mental disorders, depression, anxiety, through to no mental illness. And on this y-axis, we've got mental health. So optimal mental health up at the top here, and then poor mental health. And just acknowledging that at any point in time, someone's mental health varies. So we can have a mental illness and have optimal mental health, but likewise, there can be an absence of mental illness, but someone can still be experiencing poor mental health. And I'll just explain what I mean by that. So if I take myself, for example, I don't have a mental illness, but right now it's 5 p.m. I've been awake for a long time. We've been at a conference here in Australia all day. This is the second talk I've done today. I'm a bit tired, a bit stressed, need a bit of sleep. So you could say that I'm somewhere down here. Likewise, we could have someone that has even a serious mental illness, whether it's major depression, schizophrenia, like I mentioned, or even an anxiety disorder. But they might be engaged in therapy, engaged in treatment, whether that's talking-based therapy, medication, group therapy, a combination of all of those things. And at any point in time, or at that specific point in time, they could be experiencing optimal mental health and living a functional, contributing life. So again, with each of these quadrants, when we talk about the relationship with physical activity, there is a role, no matter which quadrant someone is in. So even if we have someone here with serious mental illness experiencing optimal mental health, exercise can play a role. Likewise, if we were in this bottom left-hand quadrant, with serious mental illness, poor mental health, there's still a role for activity. And in fact, that group is probably where we can see the most benefit and the most potential. The challenge is that it's also the hardest to engage. We need the most resources, they need the most support, and we have to provide the right structure and the right services around someone there in order to be able to participate in activity. Now, we've got this question here: what is routine mental health care? And we use this diagram a lot for a few reasons. So one, it points out this dichotomy between physical health and mental health, and the way that health systems are typically structured, where we have the psychiatrist, the psychologist at one end dealing with the head or the emotions, and then we have the physical health practitioners, the GP or the primary care physician in the US, dealing with the body. And we really separate them, or we treat them like they're completely separate. And we know that's absolutely not the case, and that the way we feel impacts our physical health, and our physical health impacts our mental health. The other issue that you can see here, and I'll talk a little bit about that, is that the image of that man is very deliberately obese. And that's because we know that poor mental health is absolutely associated with poor physical health. People that experience mental illness are far more likely to experience things like diabetes, obesity, cardiovascular disease, and ultimately to die earlier. So just for having a mental illness, someone can expect to die somewhere between 10 and 20 years earlier than the general population due to that preventable cardiovascular disease, which is really a horrible statistic. And it's where things like cycling, sport, physical activity-based programs can have a big impact in improving not only physical health, but also mental health. But so the question here about, well, what is routine mental health care? And imagine if something like this game, this is Chinlon. This is a game that's common in South Asia. That photo was taken in the Kudu Palong refugee camp in Bangladesh. It's one of the biggest, or the biggest refugee camps in the world. We've done a lot of work there looking at the role of sport and physical activity for that community. The game, you can see it's like volleyball, but it's played only with your feet. And it's this cane ball. So it's extremely athletic, and you can see that photo of that young man there. But this idea about, well, could a game like that be considered mental health care? And I think the answer is absolutely yes, if it's done in the right way. I'll hopefully convince you a little bit about that as we go on. Interesting, a few things might jump out at you in that image, and one is the lack of visibility of women or girls, and that's a big issue in terms of who has access to these strategies, and some of the safety issues as well, but we'll talk a little bit about that. So this poster here, hopefully, is unlikely to be a surprise to people. So cardiovascular disease and the risk of cardiovascular disease can be reduced through what we call the big 4 risk factors. So protecting people from smoking, eating a healthy diet, increasing physical activity, and avoiding harmful use of alcohol. So it's really not a surprise. We all know that they're good for us and associated with our physical health. Now, what we could actually do is cross out cardiovascular disease, replace that with poor mental health, and that's what the evidence tells us. That's how strong the evidence is, that all those what we call modifiable lifestyle factors have a big influence and impact on our mental health outcomes. Now, the evidence, and I'm not going to spend too long talking about academic papers because I know it puts most people to sleep. It's just to know that they are here and I can make them available to everyone. I think I've got some QR codes possibly coming up. But this paper here, this diagram, was from what was called a meta review that we published a few years ago, led by Joe Firth from the University of Manchester. And we looked at the relationship between some of these risk factors, including sleep, and some of the most common mental disorders. So you can see ADHD, anxiety, depression, bipolar, and psychotic disorders. The thickness of that line between these represents the strength of the evidence. So some of the strongest evidence we have is for physical activity across the range of conditions. And again, the challenge really is, how do we match the resources and the support to the needs of the individual? Someone living with a psychotic disorder, such as schizophrenia, may need a lot more support than someone from the general population without that disorder in order to be able to participate in physical activity. But if we can do it, and we know there are ways that work and it can be done, it can have a huge impact on not only physical health outcomes, but also mental health outcomes at the same time. And I'll give you a second if anyone wants to scan that. But also don't worry, because I can make these slides available, so hopefully they can be distributed somehow. Now, this idea about exercise and particularly depression gets a lot of media coverage. They really like sort of covering these topics, but there's a few things that we need to be careful of. And this was a piece in the New York Times in 2016 that was written about a study we published, led by a colleague of mine, Felipe Schuch, who's in Brazil and has done some brilliant work looking at exercise and depression. One of the problems is the images that we see. And you can see this image that went with that article. Having pictures of very athletic or sports models running into a new dawn does absolutely nothing to motivate or convince the people that we need to talk to. So we've got to be really careful about that, and also using images of perfect bodies, for a lack of another phrase, because that's not what the typical person looks like. So it can be actually demotivating, and we've got to be really careful with the messaging when we just tell people, hey, exercise can help, because sometimes it's interpreted as we're just shaming people or lumping yet another thing onto someone who might be struggling with different aspects of life, including mental health, and saying, look, if you just do some push-ups, it can be better. So the messaging here is really, really critical. And there was a study recently and a really unfortunate press release that compared exercise to medication and concluded that exercise was better. Now, that's a really terrible conclusion to be making that is not grounded in evidence, and is also not the message we want to be sending. Some people need medication, and that's okay. They can still benefit from exercise and activity. For some people, exercise may be enough in terms of mild to moderate mental health conditions. But it's really important that the messaging we communicate around this topic is that no matter where on that spectrum of mental health or mental illness you are, there's a role for physical activity and movement, but that we match the support to the needs of the people we're working with. Now, there was, I always enjoy the social media comments around this. I'll let you read the first one yourself, but the second one here, often a hallmark of depression is to be unable to get up and go in the first place. So while exercise is a wonderful antidote, it's difficult to implement for many. And we see this time and time again. And I do a whole lecture for students here on you just using social media comments like this. And I think it's really important. It's up to us as providers of physical activity programs to actually engage with this and not shy away from it. And to go, right, well, what systems and structures can we create? What environments can we create to actually support people that are experiencing poor mental health to be able to engage and to be able to participate? So again, QR codes here. I'll move myself out of the way in case that's there. So that is a recent meta-analysis, an updated meta-analysis we published on treatment. And there's one from 2018 we published on physical activity preventing depression. And I can summarize the results from that 2018 review. And this is where a meta-analysis is where we combine all the available data on a topic into another analysis and reanalyze it statistically. And it gives you a really nice overview of the evidence. And it's some of the strongest evidence that we can generate. So in 2018, what we found was that if we shifted the population's physical activity levels by as little as 60 minutes per week, so that's an hour a week, it doesn't have to be in one go. It could be split between different days of the week. But if we shifted the population's physical activity by as little as 60 minutes, we would prevent somewhere between 12 and 19% of incident cases of depression. 12 to 17% of incident cases of depression globally. Now, if you just think about the burden of depression and we say, right, if we get the population moving by as little as an hour a week more, it doesn't matter what they do. It doesn't necessarily matter about the intensity, but it's doing something. It's moving our bodies a bit more. We could prevent a significant percentage of the burden of depression, which is a really amazing statistic. So there's a lot of reasons to be thinking about investing in activity, not only from a treatment perspective, but also from the potential for prevention and preventing some of the burden of poor mental health. This sums it up again, quite nicely, I think. I'm sorry for the language, but I do think this is really important. Someone saying, I'm sick of people who saying who don't have a mental illness saying that I should exercise to help my mood. I don't have the energy to shower, make food, so how am I going to exercise? Just shut up. And I think this is really important. And what this speaks to is the need for us to consider what we call the social determinants of health as well. So that's the conditions in which people live, work, play. Things like poverty, social exclusion, food security, how those things can actually play into someone or influence someone's ability to participate in exercise and physical activity. Too often programs that we have are actually a luxury, or a privilege for those that can afford it, or those that have access. So we've got to think about how can we create programs that actually can support some of the most disadvantaged or the most excluded people within our communities. Now, when it comes to the mental health benefits of physical activity, not all physical activity is equal. So what I mean by that, there's 4 different what we call domains of physical activity, and I'll go through them now. So the first one's what we call leisure time physical activity or recreational physical activity. I think the last time I presented this slide, I was in New Zealand. So that's the New Zealand Women's World Cup team. So that's recreational leisure time physical activity, even though it's their job. It's a little bit tricky, but we won't get on technicalities there. The next picture is what we call occupational physical activity. So that's someone that may be a manual laborer or someone that's physically active during their work hours. Household physical activity, which is pretty self-explanatory. And this photo from Uganda is transport-related physical activity. So there's 4 different domains of activity. Now, they're not all associated with mental health benefits, which probably won't be a surprise if we think about it. So leisure time and transport do have mental health benefits. Yeah, and that makes a lot of intuitive sense if we think about it. Because if you think about what that means is that someone has the time, so there's a luxury of time. There's a luxury of safety, because there might be footpaths or road safety where they can walk. They might have access to running shoes or sneakers. So there's a lot of different factors, or they can afford a gym membership, or they can afford the registration fees to join a sporting club. So it makes sense that those two can be associated with positive mental health. It's also that element of choice, because if you're engaging in those, then it's likely a choice, which is good, and there's ownership and autonomy. Work-related mental health, work-related physical activity is associated with mental ill health. Now, again, that's not really a surprise. If you're forced to be a manual laborer for 18 hours a day, it's unlikely that type of physical activity is going to bring mental health benefits. Yeah, so it's not really a surprise. And finally, household activities, household chores seem to have no relationship. I know for me personally, they have a negative relationship, but that's not what the evidence says. So when we think about promoting activity for mental health benefits, we need to be thinking about that choice, that autonomy, that leisure time, and that transport-related activity. So it could be getting off the bus a stop earlier. We've heard all these cliches before. Riding a bike, that's the focus of this summit. So there's a good evidence there around that transport-related activity. Okay, so this was some work that was published really recently, led by Stuart Vella here in Australia. And I think this diagram is really important to help us think about the mental health benefits of activity. Traditionally, the thought has been, right, it's the minutes of activity. It's how many minutes we spend active. There's a lot more to consider. And what we're learning is that there's these other type of factors that really influence not only adherence to activity and someone's ability to engage in physical activity, but also whether they're likely to stick to it. So the first question we can see is the type or the mode. So that's what you do. And we know that can be important. What I'll just point out here is the most important thing is enjoyment. So if we really want to know what the biggest predictor of exercise adherence over the long term, it's enjoyment. We need to find something people enjoy. It's the first thing. So the second is that, just on type, what I will mention, other than the enjoyment, the type of exercise doesn't actually seem to matter. There's not a lot of evidence that one type of exercise has better mental health effects than another. We have more evidence for aerobic-based exercise compared to resistance or other types of activities, but really that's just because of the ease of actually conducting those studies and collecting that data. It's far easier to run a study where you get people walking than it is to maybe use a gym or some sort of other specialized equipment, like a bike. but there's no real evidence that one type of exercise is better than another. It's really what that individual wants to do. But some of the other considerations when and why you do it. So we mentioned those domains, for example, the transport. Another question that we're seeing more and more evidence around is the physical environment. If you are lucky enough to do something outside, it's likely to have added benefits if you can be in nature. So we hear a little bit about the green gym and the blue gym. The green gym referring to activity done outdoors, and the blue gym referring to activities done in or around water. So whether it's kayaking, surfing, swimming, whatever it might be. Again, we want to be cautious in recommending that one is better than the other. It's really not. We don't need people to have access to a lake or an ocean or a harbour in order to get mental health benefits of movement. If you do, it's a bonus, and that's great. Another important factor is the social environment, so who you're doing the activity with. We know the quality of the instructors, for example, which is the next point, how it's delivered, the social aspect. If you're riding in a peloton, and I've got a little video that I'll send a link around some work we did in Australia about that. That social aspect is really, really important and can help with the engagement, but also with the sort of mental health benefits and psychosocial benefits that we see from activity. That how it is delivered, the quality of coaches can be really important. And I'll talk a little bit about some of the risks of what we say is poorly delivered sport and physical activity. Again, we'll make these available. Now, one of the points I mentioned earlier is around the intersection of physical and mental health, and particularly the physical health of people living with mental illness. One of the reasons I'm a bit exhausted the past few days here, we've had a conference in Australia called Equally Well. And Equally Well is committed and entirely focused on reducing the disparities in physical health outcomes for people living with mental illness. So that gap in life expectancy I mentioned earlier of up to between 10 and 20 years for people living with mental illness, trying to reduce that so that people, there's equality and equity in not only life expectancy, but also quality of life. Now, the idea of the physical health of people with mental illness being a global issue was recognized in this document. So this is what we call the Lancet Commission, which is the Lancet is a medical journal, a very influential medical journal. And they run commissions on topics that are deemed of being international significance. So in 2019, we had a commission led by Joe Firth on the physical health of people with mental illness, which just is there to show how important and global this issue actually is. So the key statistics from that commission, I won't spend too long on this, but just to point out that any mental illness is associated with obesity, diabetes, and cardiovascular disease. So just for having a mental illness, someone is up to 2 times higher risk. So a twice increased risk of having those poor physical health conditions. Now, what we see disturbances or changes in these lifestyle behaviors. So smoking, alcohol consumption, sleep, physical inactivity, dietary habits. There's a disturbance in those risk factors from illness onset. So as soon as someone is diagnosed with a mental illness, we can often measure changes in these factors. Now, what that means is that there's an opportunity to interrupt and to intervene and potentially change the trajectory of these illnesses through interventions and programs that target those risk factors. So what I mean by that is, a lot of the work I've done, as an example, is in post-traumatic stress disorder with veterans and emergency service workers. Now, what we know is that their lifestyle factors change. They often become socially withdrawn, they're drinking more, they're less active, they might quit, they're socially disengaged, and diet changes as well. Now, there's a interesting work happening now around our smartphones and the potential for our smartphones to measure all of those factors and to potentially notice that there's a disturbance in those factors before we do, and even before there's mental health consequences, which is a really interesting idea of work. And the idea that we might have targeted interventions that target things like activity, target sleep, social interaction, through warning signs when we can detect that there's changes, and therefore people are potentially at risk of experiencing a mental health episode. one of the recommendations, or one of the key recommendations, was that mental health services need to provide sufficient access to supervised exercise programs as part of treatment. So this is where all those practitioners in the room providing physical activity services or cycling-based services, whatever they may be, there is absolutely a need, justification, and evidence that we need those as part of not only treatment, but prevention for people living with poor mental health. And that physical health, we need to be thinking about prevention, because once we've waited until someone's already obese and has diabetes and experiencing heart disease, the damage has been done. And it's not to say we can't help, but we really need to be thinking about this from a prevention point of view. Now, I just want to talk a little bit about some work we're doing with the Olympic Refuge Foundation, just to help people think about these sorts of interventions, and that sport isn't just sport. So we can't just hand someone a bike, for example, and expect that that's gonna treat. What we need to do, and what this is about matching the needs of an individual with matching the resources with the needs of an individual. So if we think about this pyramid at the bottom, what we're talking about is we need some level of equipment and infrastructure. So to provide an intervention, we at least need some sort of equipment or somewhere to do it. And that's really the bottom. But we'd say that if that's happening, and so, a lot of the work I do is in refugee contexts, and particularly refugee camps, we might have an organization come in and hand over footballs, for example. And that's great, but that's, really a level, what we'd say level one. It's down the bottom. It's providing that equipment, providing that infrastructure. The next level might be thinking about existing resources in the community. So community sport or physical activity programs. But often they may not be safe, or they may not be accessible or appropriate for people living with poor mental health or experiencing difficulties. Now, what I mean by safe is not physically safe, but also psychologically safe. So the right environment, the right support. If we then take those coaches or personal trainers or whoever's providing that intervention and maybe train them in something like mental health first aid, which is a program that's international, and it's basic foundational skills of mental health, skills in terms of how to recognize, how to respond, how to refer. There's different programs like Team Up or Sport for Development programs, but that might be a level 3 intervention where we've got some focused, targeted work, but non-specialized. And then finally, at the top, we might have specialized support. So university qualified health professionals. In Australia, we have exercise physiologists, physical therapists. In the US, it might be kinesiologists or whatever the training might be, but they're health professionals who are trained to provide these interventions. And I think that this can be useful to just think about the different types of resources that we need for the right person, and make sure that we're not under-resourcing our intervention. For example, if we're trying to work with a group that might have really specialized needs, that we're not just providing equipment and thinking that's going to be enough. There's going to need to be more support given. Now, I did manage to get this in, some work specifically on cycling. So this is work that we did in 2019 and also 2017. Now, I'm not a cyclist. I got punished on these 2 trips incredibly. So I think the first trip, we rode 800 kilometers in a week, and it was the first time I had ridden in a peloton in my life, and it was an absolute punish. We got through it, but we rode all the way up the west coast of Australia, raising money for mental health research and talking about exercise with communities along the way and physical activity. We also published some data on that experience, where we looked at so that image there, is 2019. So that was up the east coast of Australia, right up to the northern tip, what's called Cape York. Again, it was also a punish. I was incredibly ill prepared for that, but it was a wonderful experience. We actually measured mood states of the riders along that journey and found some really interesting things about how preparing for an event like this, how that can impact our mental health, how we can feel during, but also afterwards, how they can be a little bit of a dip. And when we've had this big thing that then suddenly ends, and the impact that can have. There is a 7-minute documentary, and I won't play it, but I'm hopeful that QR code works. And it is about cycling and about mental health and about how that can come together. So the company, the charity there that we raised that money for was called Tour Cross Oz. There's a bit of stuff online, but happy to share more resources about that as well. Now, one really important point here is about, can sport cause harm? And this comes back to that pyramid idea of just, maybe just providing access, but not thinking about the quality of the coaching or the quality of who's delivering or supervising that sport. Now, this work was done by a close friend of mine, Justin Richards, in northern Uganda, in a place called Gulu, which is a post-conflict setting. Now, Justin was there doing his PhD. He was just evaluating this sport for development program, so a football competition, or we'd say soccer down here in Australia. Or we'd say footy, actually, but we have 4 different types of footy, and I won't even go into that. So Justin was evaluating this program, and interestingly, they had coaches from the community, so local volunteers. Those coaches had never been trained in coaching, in mental health, or how to engage with youth. Now, what that meant was that the only thing they knew about coaching was what they had seen on the English Premier League, which is a man in a suit walking up and down the sideline screaming at the players. Now, these players were from a post-conflict setting. A lot of them were child soldiers. And having that stress and having a coach scream and yell at you in a competitive environment, it's unsurprising that mental health outcomes got worse in this study. And I think it's one of the most important studies for this work that we have. And what it speaks to is that importance of having qualified, trained sports coaches that can be supported by mental health professionals, and that we have this tag team, and that we approach this from both sides, where we have a mental health workforce that's trained in sport, and we have a sport workforce that's trained in mental health. Now, that's what we're talking about here with future workforces. And what does the talk I gave earlier today was talking about reimagining the mental health workforce of the future and how that can actually come together. And this is some work that we're doing together with the Olympic Refuge Foundation. We're providing what's called psychological first aid, which is similar to mental health first aid, but it's used in humanitarian contexts. And again, it's that foundational skills around mental health, how to respond safely and how to link people, link people with services. So we're providing that for physical health professionals. So that's coaches, sports coaches, physical education teachers, and that work's being led by Dr. Leslie Snyder. And then on the other side, how do we train mental health professionals so that they can be aware of sport, physical activity, and how they can actually work together, and that we can create these referral pathways. Now, we've been doing this work for a little while now. So we started in Paris with a pilot. We then went to Moldova, which is a small country bordering Ukraine. It's been significantly affected by the ongoing Ukraine crisis. We then went to Poland, where we brought sports coaches and mental health professionals together for 3 days, and we did a joint training. And now what's happening is we have one psychologist and one sports teacher in every region in Poland rolling this training out. But they're doing that together. There's joint supervision, there's joint support, which is a really interesting way of approaching it. So we're excited to see where this work goes. I'm going to finish up shortly. I just thought I'd talk a little bit about projects that we have here in Australia as well. And this is something I'm really excited about. This is a room that we call Addie Moves, that's embedded within a charity, an organisation called Addison Road Community Organisation here in Australia, in Sydney. Addie Road primarily deals with food insecurity. So there's a food pantry, but there's also about 60 other charities on the site that provide services ranging from domestic violence charities, legal aid, disability support services, refugee support services, range of services all on the same site. And about 18 months ago, they gave us this building, and we were able to convert it into what we're calling a not gym. It's the idea is that it's a safe space for people to come and participate in appropriate, enjoyable, culturally safe physical activity. At the moment, it's funded partly by Refugee Health here in Australia. So we'll just acknowledge them. And the focus is people from a refugee and asylum seeker background, particularly women, because there is just an absolute lack of services for that group where they can safely participate in physical activity. Now, that's what it looks like now, which is really exciting. And on the left, we have some of the amazing people that we've been working with, including Moza Zimbatar, who's a Kurdish refugee and asylum seeker who was detained by the Australian government for 8 years. And we also have 3 women from Afghanistan who fled the recent crisis, Marwa, and Farhat. And they painted that mural to launch the service at Addie Moves. We're very grateful for their support. As part of this program, we've gone through a really detailed, what we call co-design process. And co-design, for those that don't work in mental health, is really in prioritizing this idea that there's nothing about us without us. If we're talking about a group of people, be it people with mental illness or people from a refugee background, we absolutely need to consult, and we need to understand how we can develop programs together. So my postdoc, Dr. Grace McEwen, led this work where we went through a very lengthy co-design process with people around this exercise service. So we interviewed not only service users, but also service providers over a 12-month period. We recorded those interviews. We then transcribed and analyzed those transcripts. And we then edited the recorded interviews into a movie where we could then play that movie back to all the participants and ensure that we then went through another round of feedback to ensure that what we'd taken and what we were hearing was exactly what they wanted to say. So we did that, and we've then got this movie that we can show around exactly what's needed. And we've also written a paper that's currently under review. But I'll just talk you through the 5 key findings from that paper around it. And this is about how do you design a physical activity or exercise service for people from a refugee or asylum seeker background. But I think some of these key messages actually are applicable to lots of other, socially disadvantaged or excluded groups for whom a traditional gym might not be safe or appropriate. Those 5 points. So 1, we need to ensure cultural and psychological safety. Now, that's going to mean different things in different contexts, but a lot of it's going to mean listening to the people that we're actually working with and finding out what they need. For example, people that have experienced sexual violence, there might be issues around mirrors or touching or things that we need to be aware of in that context. So being really clear about who are the people that we're targeting and what do they need in order to feel safe in an environment. It's often this challenging our assumptions. One of the things that we learned was that the bright light in the gym was actually quite triggering for some of our attendees who had spent time in an inpatient acute mental health unit. So that was something that we needed to cover and we needed to address. So there are things that you just can't predict and we need to ask. 2, accessibility. The big thing for this service is it has to be free. So there's a leisure centre not far from where we are. People on a pension can access that for only a few dollars, but those few dollars actually exclude so many people because they just can't afford it. So that's really key, understanding that accessibility. Thinking about these physical activity programs and also how they can relate to basic needs. Now that might sound a little bit strange, but they can actually be, people can come to these services, but then we can link in with other services. So something like sport, physical activity, it's not stigmatized in quite the same way that mental health care is. So often we can use these programs to catch people, like a bit of a safety net, and we can then funnel them through to more traditional mental health services. So think about how can we link with basic services. For example, at Addie Road, there is a food pantry about 30 meters away from where our gym is. So that means that we're doing a lot of work, trying to engage with people who are using the food pantry to understand what are their needs around physical activity and movement, and how can we support that. One of the things we learned was that we need clothing, we need sneakers. So we've teamed up with another charity who provides us with free access to exercise clothing, brand new, so that we can provide it to people that need it. Another one is physical activity literacy. So it's not just we're going to lift heavy weights and get strong. There's a lot of work to be done challenging some of those misconceptions, and also the ones around body image and looks and aesthetics. Exercise is not just for weight loss, and I think often influencers online have a lot to answer for in terms of the messaging that is being sent. So we've got to separate that. We want people moving, exercising, riding a bike because of how they feel, not because of how they look. I think that's a really important point. And finally, fostering social connection. It's a critical ingredient. That social aspect is so important for recovery. It's so important for protecting and maintaining mental and physical health. So there's lots of opportunities there. That's how he moves. Now I've got 2 more slides, then I think I'm done. But for the mental health professionals in the room, if there are any, got a couple of questions here, and just that graphic there, I'll point out on anyone on YouTube, you can find these. We've made some animations, one in Arabic and one in Rohingya, targeting that community around this idea about exercise is for everyone. So those questions for the mental health professionals: do I know the physical activity guidelines, the International Physical Activity Guidelines? It's just a start. Yeah, the guidelines can be problematic, but it's really just the idea that ensuring that our mental health professionals do understand a little bit of the basics around physical health. I've got Australian nutrition guidelines, but we can replace that with the US. Peas and carrots, it's a bit of a stab at my colleague Scott Teasdale, the dietitian. We used to argue about what was more important. But in reality, the nutrition guidelines are so important, and getting an understanding of that and realizing that it is more than just saying eat more vegetables, and the role of dietitians can be so critical. Is my physical activity or nutritional messaging psychologically safe? And this is critical. Are we prioritizing enjoyment? Are we addressing food insecurity, avoiding stigmatizing language around body weight, not focusing on aesthetics, but inviting people to participate, to get curious, to understand what might work for them, focus on the enjoyment and that autonomous motivation, what might be possible in their situation so that they can participate as well. Do I know how to access additional physical health support? So, for example, here in Australia, we have very well-established referral pathways through primary care to dietitians and exercise physiologists, and also peer support, which we know is critical. It's really important that mental health professionals have these up their sleeves and know how to refer. For those physical health professionals in the room, for example, if you're running a fantastic cycling program, are you teamed up with local mental health professionals so that they know how to engage and how to refer and what can be done together? Finally, this is super important, practicing what I preach. And we're not saying everyone needs to be an athlete, but we've done a lot of work here in Australia showing that we can change the culture of mental health services. But to do that, we need to start with the staff. So if you're, beginning that journey of working with mental health services, start with the staff. That's the best way to get change and actually ensure that we can improve things long term. Now, am I a mental health informed physical activity or diet professional? And a couple of questions for you. Have I done mental health first aid, psychological first aid, some sort of training around foundational mental health skills? When I'm working with a cohort, do I actively consider the unique barriers experienced by someone living with poor mental health? So we talk about the social determinants, the conditions in which people are born, live, learn, work, and play. Now, again, I've done a lot of work in Bangladesh in a refugee camp that is extremely resource poor. Even in that setting, there is a role for physical activity and sport, but we've got to be considerate around those determinants and around what's possible and those barriers. Low mood, psychiatric symptomatology, we know that has an impact. It's hard to get the general population moving. It's even harder when you think about that intersectional disadvantage of someone living with poor mental health or in poverty or whatever that situation is. So taking that into account is critical. That same thing about the messaging being psychologically safe, we need that consistent on both sides and across health professionals. And again, finally, accessing additional mental health support. That's critical as well, and making sure that you've got a support of a mental health professional there, finding a champion that can also participate and support that. Now, I've got 5 takeaways that are all linked with songs. So normally if I was there, I'd make everyone sing, but I'll save everyone that torture for now. The Beatles. Some of us need more support than others. Our resources for our programs have to match the needs of the individual. It's absolutely critical. It's hard to say these without singing it, but I won't. Johnny Nash, we talk about these new, the emerging workforce of the future. What does that look like? Do we have a a cycling coach or a physical activity person on every mental health team, absolutely we should. That's the future of where addressing those physical health disparities needs to be. Cyndi Lauper, and I think Cyndi Lauper might have passed away today, I think, so that's very sad news. This idea that these programs can be a safety net, they can catch people, they can engage people who, sometimes in public health, we talk about hard to reach people. And I think that's a horrible language. They're not hard to reach. We're just bad at meeting their needs. These sorts of programs can do that and are really important. They can then funnel people into traditional mental health services. So we talk a lot here in Australia, we're doing a lot of work putting exercise services in mental health facilities. But what about doing the other way around and putting mental health professionals inside physical activity environments? If you're running a cycling program, do you have a counsellor, a psychologist, someone on site who can also be a part of that? Some really interesting work around surf therapy, for example, having those mental health professionals on the beach engaged in the program. So that's absolutely necessary. And finally, the co-design. We need co-production, but also co-delivery. Valuing other forms of knowledge, that lived experience is so critical. Those peer workers can do things that the rest of us can't and can engage, excuse me, in a different way. Okay, I'd just like to acknowledge Oscar, Kiara, Grace, Gulsha, the Olympic Refuge Foundation, Addison Road, Mind Gardens, and a big thanks for watching. I'm sorry I couldn't be there in person or live, but please reach out on email or social media, and I'd love to continue the conversation. And all the best with the rest of the conference. Thanks.